Welcome everyone. Welcome to our last session on the Basic Resuscitation series. My name is Dr. Benjamin Ashira, an emergency physician based in Kenya, and also with the Emergency Medicine Kenya Foundation. And the exciting part is today I'm not the one making the presentation. We have a fantastic doctor. Alexa is a pediatric emergency physician. So ideally, there are multiple things, emergency physicians, and then there's those emergency physicians who love kids. So Alexa is one of those who loves kids. I barely see any kids, so I figured I may as well get you a professional who sees more kids than I do. So Alexa grew up in Guatemala, still in Guatemala. Alexa, this is in Mexico, right?
It's its own country, actually. Guatemala is just below Mexico.
Oh, cool. Yeah.
Tiny
All right, Ash. So she attended Duke University, where she studied neuroscience and global health. Fancy. And she worked as a research associate in the Hospital of Joint Disease in New York before moving to DC for a global health course fellowship and Inter-American Development Bank. She went to medical school in Northwestern Chicago and completed pediatrics residency in Children's Hospital, Los Angeles. So as I'm sure you're wondering, why am I introducing an American to come and make a presentation about our challenges here in Kenya? Well, Alexa did spend a whole year in Kenya after her residency, where she was a postdoc research fellow with AMPATH East Africa. So Alexa, were you in Eldoret all this time?
In Eldoret, yeah.
Awesome. Yes, so she spent a year in Eldoret looking after kids there and enhancing her global emergency, pediatric emergency medicine skills. She's now in her second year in pediatric emergency medicine fellowship at Children's Hospital, Los Angeles, and she enjoys walking her dog, yoga, art, and travel. Guess that's how she landed in Kenya. Well, but today she's our host for this exciting talk about crashing babies and kids. She's the expert, so all the hard questions, put them in the chat. And then also you can use the Q&A function, and I'll try and answer some, but I will just leave the hard ones for Alexa. So Alexa, you may kick off, and welcome. And thank you very much for presenting to this large group of Kenyans who are very excited, and actually international folk, who are excited to learn about the crashing baby and kids. So welcome.
Well, thank you so much for having me, and thank you so much everybody for joining. Please feel free to participate in the chat, and if anything comes up that sounds very different from how things are done in Kenya, then please don't hesitate to bring that up as well. I'm learning just as much as you guys are every day. So crashing babies and kids, it's kind of a broad topic, and people have all sorts of different feelings about it. So to start off, what is your primary emotion when you think of taking care of a sick baby or child? Are you more like the person in panel A, or are you more like the person in panel B? And feel free to put in the chat which of the two you align with most when you think of taking care of a sick baby or child. Let's see, we have A, yes. Okay, so that's generally what I hear from most people. We're terrified because the stakes feel high, and as we've learned before, children are not just little adults, they have different physiology, right? So hopefully by the end of this series, we'll make it so that you're moving a little bit closer to being this person in panel B. So like I said, kids can be very intimidating. You're not alone in feeling that. There are a lot of differences between taking care of a sick child and an adult. Mostly the things that come to mind are weight-based dosing for medications, very different from adults who have standardized dosing. Different ranges of normal for vital signs, which change, it seems, all the time, right? From 1 month to 2 months, it might be pretty similar, but from 1 to 2 months to a year can be very different. And then structures are smaller. If you're thinking of doing procedures in a small child, you're going to have to make much finer movements, and the anatomy can be very different. So with all that being said, it's just very important to have a systematic approach. These are just some pictures of what we probably all hope a pediatric encounter would look like, right? The children are engaged, they're looking at us and smiling, they're curious about the stethoscope, and most importantly for me as an emergency physician, they look alert and they look stable, they look pretty well. In reality, this is what most of my encounters look like, right? Kids are not happy to see the doctor. They're terrified, they'll scream, but I'm okay with that because these children because they're screaming, are telling me that they have an airway, right? So they're not the sickest child in the ED. They're responding to me walking into the room, and I can tell that at least my A is taken care of, right? Airway. The children I truly worry about are these kids. You know, you walk into the room and they're just kind of lying there. They're not really responding to your voice when you're speaking to the parent. There might be a little bit of low tone that you're kind of observing from the door. So these are the children you should really be concerned about. So to go over the approach that Dr. Washira introduced last week, it's very similar in pediatrics, but we'll just review it for the adult patient first. So number one, you're asking yourself, does the patient have a pulse or not? That's important because if the patient does not have a pulse, you're starting CPR, right? In kids, there's a little bit of a caveat to that, which we're not going to get into too deeply today, but in small babies, for example, you really want to start chest compressions when the pulse is under 60. But that's a separate topic that we can maybe do at some other point. Your second question is trauma, yes or no? And that's important because, as Dr. Washira mentioned last week, we want to start planning for C-spine stabilization if that's necessary. Next, A, airway. Is it open, maintainable? Do we need to intubate? So open, maintainable, is the patient protecting their airway? Do they have the mental status to protect their airway? Are there any signs of obstruction? Breathing. This is where the real, bulk of your pediatric patients are going to fall, breathing and circulation. So for breathing, we're going to look at the rate. We're going to look at air entry, the patient's color, the patient's effort, which refers to accessory muscle use and using the chest wall to breathe, and then the patient's saturations. And an easy mnemonic to remember all of those things is RACEs. Circulation, we're looking at the heart rate. We're assessing the patient's AVPU score, which we'll talk about a little bit more later. Looking at the patient's color, which is the sign of perfusion. We can add in an EKG or ECG, though in the pediatric patient, it may be less relevant than in the adult. Important adjunct. And systolic blood pressure. Then disability, D, we're calculating a Glasgow Coma Scale, which is modified in pediatrics from the adult Glasgow Coma Scale, and we will go over that as well. Assessing pupils and getting a random blood sugar. And then finally, exposure, where you're looking at the skin and looking for any injuries or rashes. So just one major difference between the etiology of cardiac arrest in kids versus adults. Children generally will present in cardiac failure after they've reached respiratory or circulatory failure. So the number one reason for cardiac failure in kids is respiratory failure. And what that tells you is by the time a child comes in something like cardiac failure, their respiratory and circulatory systems have likely already failed. So even if you're doing chest compressions, it might take you a little bit longer to get that patient back because they're already so behind from like a respiratory and circulatory standpoint. That being said, there's a lot of area to intervene before you get to something like cardiac failure. In adults, since they've had so much more time to accumulate chronic diseases and they very often will present with a primary cardiac presentation, then it makes a lot of sense for your first thing to be getting a pulse and seeing whether or not you need to start CPR. In children, because of that, because we're not immediately as concerned about sudden cardiac presentations, and because children are also just very different behaviorally, we have something called the pediatric assessment triangle. And this is meant to be a very quick assessment of the patient from the door. So you're looking in through the door at your patient and you're assessing three things just based on what you can see without laying any hands on them at all. You're looking at the patient's general appearance, circulation to the skin, and their work of breathing. If all three of those are intact, then you can say from the door, okay, this patient looks relatively stable from what I can see. If the patient has increased work of breathing, but is alert and turns to you and is making eye contact, then this patient is one who you're going to walk in thinking, I'm already framing in my mind that I think this patient has respiratory distress. Respiratory failure is when the work of breathing has become so severe that their appearance changes. So their mental status is starting to wane, or alternatively, something has affected the mental status that is impacting breathing. Shock refers to circulation to the skin with or without impaired appearance. CNS or metabolic would be just impaired appearance. So the patient looks unwell, but is actually breathing okay, and their perfusion looks okay. And cardiopulmonary failure is all sides of the triangle are impaired. And this is important because of these patients, right? Whatever information you can gather about the pediatric patient without actually having to touch them, approach them, is important because it will help you be more effective in your exam, and it will help you target what you think is most important when you're actually laying hands on them and examining them. So before we start, let's just quickly review some vital signs for pediatric patients. Just a caveat, this is really difficult to remember off the bat. It takes a lot of repetition to kind of get the sense of, okay, in a patient this age, I should be looking at a respiratory rate in this range. We have these little pocket reminders of what normal ranges are, and I still reference them. You will get a sense for what is normal and what is not over time, but don't feel shy about offloading some of that memory onto something like a PALS card or a badge. We have these little badge reminders with vital signs that we all carry around at my hospital, and I think it's really helpful. Rule of thumb though, for neonates, any child with a respiratory rate over 50, you should be asking yourself, why is that so high? By 6 months, and between like 2 to 6 months, the same should go for a respiratory rate in the 40s. So once you're in the 40s, you should be assessing the patient and figuring out why you think the patient is breathing that fast. Over 1 year, the patient can be breathing in the 30s, but once they're getting to the 40s, I would start, antenna should be going up as well. And then 10 and older should be breathing in the 20s or so. But many adult patients will be breathing in the teens, and that's totally fine. In pediatrics, that's usually not normal. So you should be assessing that. And then for saturations, that's the same as in adults. For healthy patients, we generally want to keep saturations above 90, 92, some people say. And then for patients who have chronic problems, you would want to target like 94, just because they would be at higher risk for deterioration. So heart rates and blood pressures. I like to say any heart rate above 150 in my emergency department, I am investigating. It's true that neonates have normal heart rates between 100 and 150 and can sometimes, when they're distressed, go up into the 200s. But I really want to know sorry, I see a question in the chat here. Let me just see. Or Ben.
It's okay, not yours.
Okay.
I'll sort it out.
Okay, sounds good. So any heart rate above 150, you really want to be investigating and figuring out why and what you can do to bring it down. It's true that if you catch the baby at a bad moment, they're screaming, their heart rate can go up into the 200s, and that can still be a stable patient. But you just want to make sure that you're figuring out why and that you feel okay with the explanation, so that you don't have to intervene immediately. 6 to 12 months, a heart rate of about 100 is okay. 150 becomes too high at that point. So that is definitely a kid you're going to assess and trying to intervene on. And then by age 6, you should have a heart rate under 100 most of the time. It shouldn't be 60 like in the adult, but it should definitely not be 150. Blood pressures, neonates should have a systolic blood pressure of about 70. Ages 1 to 10, you can use this rule of thumb where you do systolic blood pressure of 70 plus 2 times the patient's age. So if the patient were 2, then you would want a systolic blood pressure of at least 74. Over the age of 10, you want a systolic blood pressure of at least 90. Just to know, with this rule, this refers to the 5th percentile for blood pressure for age. So, it's pretty low already. So hopefully you will have caught it a little bit before that and started to intervene. Okay, so this is our modified approach to the pediatric patient. Almost exactly the same as Dr. Washira's, except we're adding in the pediatric assessment triangle at the very start. So let's start with this patient. Okay, so what do we think pediatric assessment triangle wise for this little patient? Anyone want to put what they think in the chat? Are they worried, not worried?
Maybe you can play the video again. Was there a sound on the video?
Yes, there should be. Did you hear it?
No, I think just unshare, then you share with, click on the button that says share with sound. Maybe unshare your screen and then share again with sound, and should be able to hear. No, it's the whole PowerPoint presentation.
Oh, the whole PowerPoint presentation. I see. Okay.
Yeah, so unshare. And then when you start sharing again, there'll be a button at the bottom that says share with sound.
I see. Okay. Sorry about that, everybody.
So share, then the bottom left.
Got
that
it.
one, yes. Then you can play it.
Perfect. Okay. All right.
And I see most people are not actually worried about that child, but yeah.
Most people are worried?
Not worried.
Not worried. Okay. Perfect. Can you hear now?
Is it playing? Yes, we can.
Okay, fantastic. And agreed. So not worried about this child, right? This child is annoyed. She's crying. Maybe she's hungry, but she's sitting up. She's alert. She has an airway. She looks like she has sort of rosy cheeks. Her complexion is the same color as her mother's, and she doesn't seem to be in significant respiratory distress. One caveat to that is that, we can't really see what her belly is doing, and she is crying. So it's possible that she is having a little bit of difficulty breathing. We would need to, undress the child, do a really good respiratory exam. But right now, my pediatric assessment triangle for this patient is that this patient is stable. So I started out with an easy one for you guys, okay? We're gonna do the next one now. And listen carefully, okay? All right, what do we think for this patient? What do you hear? Worried, very worried?
Very worried.
Very worried, yeah. What sounds do we hear? Stridor, exactly. Yes, worried, stridor, yep. So you guys, your assessment triangle, your spidey senses are going up, right? This patient is in respiratory distress. And that inspiratory sound that you heard, the really high-pitched sound, I'll play it again, is called stridor. That sound is caused by inflammation of the tissue above the vocal cords that causes a really high-pitched sound when the patient inspires, okay? And inspiratory stridor at rest is something you should really take seriously. Stridor in kids is generally caused by croup, which is a viral illness that causes inflammation of the airway up here. It's not a problem in adults because the structures in the adult neck are so much bigger that a little bit of inflammation, it'll be painful, uncomfortable, but it's not going to compromise your airway. In a baby, especially a baby like him who's not crying, not screaming, and still has stridor that is that significant, this is an emergency that you're intervening on, right? Or at least a very significant urgency. For stridor at rest, we generally start with racemic epinephrine, racemic adrenaline. So it's an inhaled nebulized treatment, and it will help vasoconstrict all the soft tissue in the neck and make the airway more patent and open it up so that the patient can breathe. The true treatment for croup, though, is steroids. So try to get those in as quickly as possible. Okay, and croup is most common in babies aged 6 months to 3 years. So if you have a patient that's older than that who has inspiratory stridor, I would, kind of broaden your differential and think about what else it could be. Things like foreign body are important to think about, especially in toddlers who are putting all sorts of things in their mouth. And then any other signs of an allergic reaction, you might be thinking something like anaphylaxis. There are usually other signs on the face that you could use as clues, but croup should really be most prominent in babies between 6 months and 3 years. All right, So just to speak a little bit more about the differences between the adult and pediatric airway, again, this could be a lecture onto itself, and we're not really going to talk about intubation, but it's just important to remember this as you're evaluating the patient's airway. Number one, newborns are obligate nose breathers. So when they're congested or they have some sort of compromise to the nose area, then it's going to be really difficult for them to breathe, and it's going to be really difficult for them to feed. Okay, that's different from adults who, if you're congested, you can change to breathing through your mouth. In addition, babies can't blow their nose very well, right? So that's going to be something that's going to make them much sicker than adults. They have rounded occipits, so the backs of their heads are very rounded. They have relatively large tongues for their mouth. Their epiglottis in the back of, at the level of the vocal cords is floppy, as opposed to kind of like more cartilaginous. And the entire airway, the entire vocal cord structure and the box is further forward, so it's more anterior, and their neck is much shorter. That's important when you're intubating, because in the adult, you hyperextend the neck to get the best view when you're intubating. In a child, you want them in a little bit more of a neutral position, so you can extend the head and neck, but you're not going to hyperextend it. And then often in younger children, using a shoulder roll to lift up the body so that it is at the same level, or at a more neutral level, because of that rounded occiput, will be important. All right, let's move on to the next patient. This is a little bit of a silly video. There are some things in it that are not super accurate, so just keep a really close eye on the patient. Decide whether you think this patient is stable or unstable, and how you're feeling based on the pediatric assessment triangle. And then we'll have a little bit of a discussion of the video, okay?
Shortness of breath. It says history of asthma. When we arrived, the fire department was there giving the baby oxygen.
Y'all all right? How you doing, baby? How the baby doing?
He's definitely having trouble breathing, so we had to get him into the truck quick to get a nebulizer on him. We can give you something to breathe in. The nebulizer will help open his lungs and ultimately help him breathe better.
Y'all got that new spot. This one on. Where the mama at? I want you to come sit right here, baby.
All right, little one. Don't run off.
Oh, I can hear him from here. You got a little junk up in there.
Junk. All right, I know.
It's gonna be all right, man. I know, huh?
You wanna hold that?
So we're just assessing for any type of distress. Obviously, the kid's breathing really fast and is grunting and having trouble getting air in.
I don't want you to chew on it.
What's his name?
I want you to breathe on it.
George?
Has he been diagnosed with asthma? Okay. This child is newly diagnosed with a case of asthma.
You know what's funny though? Like,
Okay, patient number 2, 6-month-old with cough, requiring a nebulizer. What do we think about the video, about anything you heard, anything you noticed that maybe is different from what you usually think for a 6-month-old? Pneumonia, unstable child.
I would
Thank you.
probably have kept the child with the mother.
Sorry, say that again.
I would probably have kept the child with the mother.
Yeah, exactly. Acute asthma exacerbation, asthmatic. Yeah, thank you so much for participating, everybody. This makes the discussion much better. So agreed, any kid with respiratory distress, especially at this young age, try to make them comfortable. Keep them with their mother, keep them with their caretaker. For a lot of the exam too, this is kind of, in addition to the primary approach, but a lot of the exam can be done on the parent's arms, and that can actually increase your chances that you'll get an accurate exam and that the child will stay calm. For this child, so he's 6 months old. We generally don't really diagnose asthma in a 6-month-old until they're just so young. We call it reactive airway disease until they're about 2. Once they're 2, if they've had multiple presentations for wheezing that has improved with bronchodilators like salbutamol or albuterol, then we can say, all right, this child likely has asthma. For this child, if you noticed when they picked him up, he was also awake, alert, didn't seem like he had any change in his tone. Yes, he was coughing a lot. And the emergency medical provider mentioned that he was breathing quickly, so he was tachypnic and he was grunting. Those are all things to take really seriously. But he's alert. So in terms of the pediatric assessment triangle, this child, I would say, also is in respiratory distress. So you're walking up to the child, we're checking the pulse. We know this is not a trauma patient. Their airway is open and maintainable. We heard the baby scream, right? The baby cried there. That's really reassuring. And then breathing. So for a patient with asthma or with wheezing, I think usually when we hear wheezing in the chest, that's actually reassuring. If you hear a silent chest or diminished breath sounds in a patient with asthma, that should be really, really, really concerning to you. That's an emergency, especially if it starts affecting their saturations, and especially if the patient is unable to vocalize. So in a patient this age, it's a little bit more difficult. But if you had a kid who was 5 or 6 and had a history of asthma, and they came in and you listen to their chest and you're like, oh, I don't hear any wheezing at all. But the patient's sitting there really still, where their expiratory phase is much longer than their inspiratory phase. And when you're asking the patient questions, they're nodding or just shaking their head and not wanting to say anything. That's a very sick patient who you want to start treating with bronchodilators immediately and steroids immediately, because they've gotten to the point where their asthma is not only causing wheezing, but the airways have been reconstructed, or they sort of like, the inflammation causes swelling over time during an asthma exacerbation, and the swelling is really difficult to reverse. So it's best to catch asthma exacerbations early on, especially in little kids, especially if they have a history of requiring serious intervention for their asthma, because if you let the inflammation go for a day or two, then it can be much harder to reverse. All right. One more thing I will say about wheezing in babies under 2 is that very often wheezing in babies under 2 is due to bronchiolitis and not asthma. You will never be wrong for trialing a nebulized treatment, but this is another one of those situations where I would ask myself, what else could it be if it's not asthma? Many babies will actually, they'll have exams that will have wheezing sometimes and crackles other times, and that's usually part of like a viral illness. So same type of thing, we addressed breathing. This child is getting his nebulizer, so we're going to check circulation, disability, exposure in every single patient, and then start again. All right, next patient. Okay, what do we think about this patient? What did you notice as you were just looking at them from afar? Chest drawing in, exactly. What else? Chest indrawing, severe respiratory distress, yep. Lower chest wall indrawing, exactly. Yeah, yep. So this child is having severe subcostal retractions. So pulling in the soft tissue at the base of their chest wall. He's also, if you hear, doing the grunting sound, right? The indrawing of the chest at the bottom with the grunting, especially because this patient looks really tired and their respiratory rate is not super fast. It's actually, I calculated it watching the video earlier, it's in the 40s. For a baby this age with a respiratory illness, 40s is actually like a little bit lower than I expect. And my worry is that he's tiring out, right? Subcostal retractions, and really any retraction in the chest wall, which I think some people also call recessions or chest indrawing is what I saw in the chat mostly. Those are caused by the patient creating like more or trying to increase the negative inspiratory force to prop their airway open. And then there's collapse of all the soft tissue around the chest wall while the patient does that, because the chest wall in babies is just much softer than in adults. So you can see these signs much more clearly. The grunting is also, the patient is trying to push air into their airways to create auto PEEP. So they're trying to prop open their little alveoli, which are collapsing. And by doing the sound, they're pushing air into the alveoli. So that's a patient who you need to start thinking, this patient may need positive pressure or some sort of help pushing air into the little airways. So this patient has pretty classic bronchiolitis, right? He is about, maybe 2 to 3 months old, has a lot, maybe a little bit older, actually more like 4 months, has a lot of congestion in the upper airway that you can hear, and is also having lower airway signs because you can see the subcostal retractions. And bronchiolitis is a viral illness that will affect both upper and lower airway. It's one of the most common respiratory illnesses we see in little babies. And this is another one where the most common age is under 2 years old. If you have a child who's 3 years old, I would ask myself, what else could it be? Because they're not in the typical age range, okay? And our number one intervention for a child like him is suction of the upper airway. You can do a quick pass with a suction if you're in a hospital setting and you have a deep suction, like a soft plastic suction catheter. You can put it down just to the back of the throat and come out and help the baby extract some of that mucus. If you only have the bulb suction, that also works really well, but babies cannot blow their nose, so you have to help relieve that upper airway obstruction. If the baby is still breathing this hard after relieving the upper airway obstruction, then I would usually move on to get a blood gas and see if they're able to ventilate. So are they able to get rid of their CO2 effectively? Otherwise, you may need to think about a more advanced airway or something like high flow nasal cannula can often be really helpful in babies this age. Moving on to circulation in bronchiolitis, always, it's important, since babies, like we said, they're obligate nose breathers, right? So if they can't breathe through their nose, then it will be really difficult for them to feed as well. So it's always important to check their circulation, see whether the baby is dehydrated, because it's very easy to get dehydrated with something like bronchiolitis, and rehydrate as necessary. One last thing is for bronchiolitis, actually, with high fever after 2 days or so, 2 or 3 days, I would consider getting a urine sample, because there's a high proportion of babies with bronchiolitis who will also have urine infections. And that is because they get so dehydrated that the small amount of urine in their bladder will just sort of sit there and can get infected. All right, so we said respiratory failure. Let's now look at a baby who has bronchiolitis as well, likely, and has retractions, but may not be as likely in distress.
Hi, baby.
What is it?
Right, so this patient is having retractions down here, but he doesn't look tired like the other baby. He's alert, he's looking at the caretaker, he is not about to tire out. So definitely, retractions alone should make you a little bit worried, but it's really retractions when the patient looks tired that is scary. A couple other things under the respiratory category. So what do we think of this patient right here on the left? What do we think of her position? Tripoding, exactly, nice work. Cardiac, yeah, what else could it be? Tripod, yeah. So generally tripoding, we think of it looking like this, right? It's a common developmental milestone for little babies, but also if the patient looks sick, then we immediately will think of something in the upper airway. This patient, I thought this first picture was actually really good because it doesn't have to be the hands in between the legs, even though that's what we traditionally think of. It's just the patient is sitting forward a little bit and supporting their upper body with their 2 upper arms. So they have both hands firmly planted on the bed or on the table, and they're leaning forward. They do that to align all the structures in the neck so that as much air as possible can get in and out. And it's generally something that kids do in response to upper airway inflammation. the textbook reason for doing, or for assuming the tripod stance is epiglottitis. Patients will often be drooling as well. It's less common of a diagnosis in the age of vaccines. So the Hib vaccine, Haemophilus influenza B, has really decreased the incidence of epiglottitis, but it's always something to keep in mind. These are also patients, as Dr. Washira mentioned earlier, who you're keeping really calm. You're having them sit with their parents while you're figuring out how to establish a definitive airway, and then you would treat epiglottitis if it's caused by H. flu with IV antibiotics. One more sign of severe respiratory distress here. What do we think of this little baby? I'll play it again. It's a short video. Nodding, yeah, nodding or head bobbing. This is a sign of respiratory failure in babies. There's another hint in this baby in particular that he or she is in respiratory failure, and that's that they are using oxygen, right? So they're not able to maintain their saturations without supplemental oxygen. That in itself is respiratory failure. The reason little babies do that head bobbing motion, and it really is most common in babies under 6 months, is because, again, they're pushing air into their lungs and creating increased negative intrathoracic pressure to pull air in. And when the muscles relax after they've done that pulling motion, the head moves forward because their necks are so floppy under a certain age that they can't maintain their neck straight after they're trying to pull air into their airway. So these two signs are, impending respiratory failure or progressing respiratory failure, and I would take both of those very seriously. Okay, any questions so far? I know we've been going pretty quickly. I'm curious, is it nodding or head bobbing, or is it the same thing? So it would be the same thing. I've always learned it as head bobbing, and because it almost looks like the head is floating in the water, right? It's kind of like this little motion like this. Nodding, I'm pretty sure would be the same thing. I've always heard it referred to as head bobbing, but I'm pretty sure it's the same.
Yeah. So I was curious because I think I'm seeing a lot of my colleagues calling it head nodding. I know it as head bobbing. So I think it's probably a teaching that's locally that it's nodding. So I guess it's just a school of thought. But yeah, that's why I was asking the question. So I have a feeling in Kenya they taught it's head nodding. Where I went, they would call it head bobbing. So good. All right, good stuff. Well,
got it. Yeah.
All the questions seem to be answered. Good.
Okay, perfect. Yeah, there will likely be words that we use differently, but the important thing is that you recognize these signs on your physical exam as something that you need to intervene on immediately. And the thing is, children can they're really fit. They're like little athletes. They can compensate until they can't. So as opposed to an adult patient who will really slowly get sick over time, and you will see them deteriorate kind of like gradually, children can look great until they don't. And because of that, it's important to intervene when you notice signs early. Okay, next patient.
New York plays music in relative obscurity until passing away in the 1990s. But thanks to this clip on YouTube, new fans are finding the summer 40 years after the fact. There's a memorial website, and 3 of the songs now appear on a new Rhino Records box set. It's great to finally see that.
Okay, so this patient needs a little bit of history. So this patient had, he's 2 years old. Mom says he's coming in with 2 days of vomiting multiple times per day and diarrhea multiple times per day. Mom's really concerned because he hasn't had a urine diaper since early that morning. So it's been like 10 hours and she just can't keep any fluids down for this patient at all. The patient, pediatric assessment triangle wise, what do we think? What are we going to be looking for first? So I see vomiting, excessive secretions, drooling. Yeah, so lots of fluid losses, right? So when a patient has a lot of fluid loss, we're going to be honing in on circulation. Is this patient losing so much fluid that they're becoming hypovolemic, where they're losing so much fluid that they can't perfuse their end organs well, right? Vomiting, hypovolemic. Yep, exactly. Yeah, so let's go through this approach one by one for this patient. So assessment triangle, we said we think this patient may be in shock, right? We're going to go over his vital signs really quickly, but pulse, no pulse. He's awake, alert, so I'd be surprised if there wasn't a pulse, but we will still check. By the way, in pediatric patients, the best places to check a pulse are the brachial pulse right here and the femoral pulse. Other pulses are generally unreliable, okay? So I would always check in those two areas. Trauma, no trauma. This patient, we don't have any history of trauma, so we don't need to worry about it right now. Airway, open, maintainable, intubate. So this patient is a little bit tricky in that sense. You don't want to get too into your head about it because the patient's vomiting, right? So they are at risk for aspiration, and there is a lot of pooling of secretions in their mouth. But in general, they're able to maintain their upper airway. So this is not a patient who you need to worry about intubating. It's just a patient who you might want to help out with some of those secretions so that they don't aspirate and give themselves a pneumonia. Breathing, so it's kind of tough to tell from this video because he's retching. So the benefit of having a child in the emergency department or seeing them in an emergency setting or inpatient setting is that you can go and reevaluate them after you've initially intervened. I'll tell you, for this patient, when you listen to their lungs, they're nice and clear. His saturations are perfect. And in terms of his color, he looks a little bit pale maybe, but there's really no respiratory effort aside from the retching. Okay, so we're really going to hone in on circulation here on this kid. So rate. So his heart rate, I put it up here in the corner, is 135, and his blood pressure is 95/55. What do we think about those vital signs for a 2-year-old? This is a really tough question because we don't have the little guide, right, by age. So I can go ahead and tell you a heart rate of 135 for a 2-year-old is pretty high, but the blood pressure is normal. Okay, so this patient is in compensated shock, most likely. Their heart rate is high, but their blood pressure is still maintained. I saw a note about how to assess dehydration. So lots of different ways that you can in a child this age. I would look at some of the ancillary signs. So for this kid, if you see he's making tears, anytime a child is making tears, then you know that they are, I mean, it's reassuring. It's not the only thing you should look at, but they're not crazy dehydrated if they're making tears still. I told you guys that the patient hadn't had urine out since this morning, and that is a sign of dehydration for sure. For little babies who are closer to, like, in the neonatal period, you expect there to be 8 to 10 wet diapers per day. And if you're measuring it perfectly, which we usually are not, smaller children, you expect 2 cc's or 2 mLs per kilo per day, per kilo per hour. And for older kids, you expect 1 ml per kilo per hour, okay? But really, any child who hasn't had urine in 8 to 10 hours is dehydrated, and you should be intervening. You can also check capillary refill. So you are going to hold pressure on either the nail bed or on the finger for 5 seconds and then let go. The color should return to the skin or to the nail bed within a second or two. Anything more than 2 seconds is too long. So this kid, his capillary refill was about 2 seconds, maybe a little bit, maybe closer, maybe, just above 2 seconds of getting to 3. And so he is probably, mild to moderately dehydrated, and our heart rate and blood pressure tell us that he is in compensated shock. So we'll talk about that in a second too. But pediatric assessment triangle wise, again, awake, alert, and what I'm really focusing in on is his hydration status. So what is shock? Shock is the inability to meet the metabolic demands of the body, which results in end organ dysfunction. Some of the main things you're going to think about when a patient is in shock is compromised perfusion, low blood pressure, altered mental status, low urine output. There are many others like bowel hyperperfusion and shock liver, but in a clinical setting without labs, and for most patients, these are the things you can really rely on, okay? The types of shock there are 4 big categories that we think of: hypovolemic, distributive, cardiogenic, and obstructive. In children, the first 2 are really the most common. So hypovolemic shock and distributive shock due to sepsis or anaphylaxis, for example. For the purpose of your primary assessment, so what we're talking about today, right? A, B, C, D, E, it's helpful to differentiate between cold shock and warm shock. Cold shock is when you have cool extremities, mottled skin, your cap refill is greater than 3 seconds, you have weak pulses, and high systemic vascular resistance. So as Dr. Washira talked about last week, and this is a case where you have low contents of your tank, but your pipes are totally fine, okay? Warm shock is warm extremities, flushed skin. You have what we call flash capillary refill, which is when you press on the nail bed and you let go, the color comes back immediately, almost too fast. Bounding pulses, and this is when you have low systemic vascular resistance, and as a result, you increase your cardiac output to perfuse your end organs. This is usually seen in septic shock, and the problem here is that your pipes or your vasculature is leaky. It becomes leaky because of an inflammatory response to infection and cytokine release, and the body is no longer able to kind of tighten up all of the vasculature in the periphery. So you become really vasodilated. And in this case, there's often enough in the tank, but you will have to probably give more than what is usually required because you don't have the systemic vascular resistance to pump that blood forward. And just again, like we talked about in the beginning, the pump, so the heart will rarely be compromised in kids, rarely. It really will only happen in children who have congenital heart disease, and they're kind of like a different kind of patient to think about in an emergency setting. This is another important thing to think about. So compensated versus uncompensated shock. That patient that we just talked about, who was having the retching and the vomiting and diarrhea for a couple days, who had a high heart rate but normal blood pressure, is in what we call compensated shock. This is a patient who you have a huge opportunity to intervene on and help make better, okay? Because like we said before, babies are like little athletes, and they're very metabolically active, and they can compensate for a long time before they crash. So by the time you're in uncompensated shock, which is where you're seeing end organ dysfunction, super tachycardia, tachypnea, low blood pressure, it's gone too far, okay? This patient probably should have had some sort of intervention sooner. Okay, next patient. Any questions so far, by the way?
So Alexa, I was just asking about, so in that child, the previous child who was drooling, vomiting, diarrhea, excessive, salivation. In a crawling child in our setting, I think organophosphate poisoning, having drunk something would be something that would probably put, I'd be concerned about in such a child, like they probably drank something potentially. Because diarrhea and vomiting is fine, but the drooling, and I think also in the picture the child was actually tearing. So I think I would definitely be considering organophosphate poisoning in that one.
Absolutely. Yeah. Thanks for bringing that up. I honestly hadn't even thought about that for this child. And that speaks to the power of working in teams in the emergency setting, because you will see things that other people don't. And having a team is one of my favorite things about working in an emergency department, because, 2 brains are better than 1. And it's always important to keep your differential broad. So yeah, poisoning, that's again, another talk that we could have like in itself. There's a whole world of toxicology to explore. And in kids, the interesting thing about toxicology is that it's usually unintentional, right? They're usually exploratory ingestions as opposed to adults who will often take extraneous substances either for recreation or for self-harm. So.
All right. Yeah. There's some 2 questions. Someone wants to see the previous slide, and then there's a question about shock.
Yeah, 1 second. Okay, let's go back.
Yeah, so they want clarification on compensated and decompensated shock, I guess.
Okay, So yes, great question. Also, these concepts are really, really complicated. Shock took me a long time to really feel comfortable with. The idea is, and there are lots of different kinds of shock. And we're going kind of quickly today. This is the kind of thing that I think you could really delve into in a lot of detail. But the big idea is, in compensated shock, you are increasing you're increasing your heart rate. So you're making yourself tachycardic. Your body is making itself tachycardic in order to perfuse all of the organs in your body as well as possible. And there are different ways that you can achieve that. You can, because cardiac output is heart rate times stroke volume, right? So how much blood your heart can pump out is based on how fast it's pumping and how much fluid it's pumping forward. Okay, so to increase your cardiac output, you can either make your heart beat faster, or your stroke volume, which is really dependent on the both the strength of the squeeze and how much fluid is in the tank, needs to be increased. In compensated shock, you will just be making your heart beat faster because you can't really add in extra fluid to your own body. As doctors, or as healthcare professionals, we can add in extra fluid and give IV fluids to help improve stroke volume. But the way the body will first start addressing either low intravascular volume or low systemic vascular resistance, so either dehydration or blood loss or infection, the result of those two things, the very first thing your body will do is make the heart beat faster to send enough oxygen to as many organs as possible. If that isn't working, then at a certain point, your blood pressure will become low. So it will fall off as like a second stage to being sick, if that makes sense. But if you can increase your heart rate initially, then you can continue sending enough oxygen to your end organs. Eventually, either because you have such low contents in the pipe, or the pipes are so leaky, or your heart tires out, you're not going to be able to send enough oxygen forward just by making the heart beat fast. And that whole thing is going to cascade and your blood pressure will eventually drop. That's kind of a simplified way to think about it. But it depends on the kind of shock, and this takes a long time to wrap your head around. So I hope that kind of helps clarify it. But I think the main takeaway point should be that in compensated shock, you will see tachycardia only and your blood pressure will be normal. So you really just need to focus on addressing that tachycardia, because the next step is going to be that your blood pressure will fall, and that is a sicker patient. The idea of lethal diamonds, I don't know that idea.
Yeah, let me explore it further.
Okay.
You can continue and find out what it is.
Okay. All right. Sounds good. All right. So next patient, what do we think about this patient based on the pediatric assessment triangle? So I'm very worried about this patient. Okay. Altered mental status definitely looks like it. I'll tell you, because this is not a video, so it's a little bit difficult to know exactly what I'm getting at here, but let's pretend this patient is actually breathing just fine, and is really kind of like lying there and not moving too much. But when you walk into the room, lethargic, exactly. I would definitely describe this patient as lethargic, sunken eyes. Yeah, exactly. So this is a patient who I am rushing into the room for, right? We're going to check to see, does this patient have a pulse or not? So I'll tell you, for the purpose of this discussion, this patient does have a pulse. It's actually bounding. We don't know any history of trauma. This patient's airway is open, maintainable, so we don't need to intubate right now from an airway standpoint, but we're really going to need to think about this patient's mental status. Okay, so luckily this patient, as you approach her, starts kind of stirring a little bit when she hears your voice. You do see her intermittently moving her arms and legs spontaneously. And she's sort of like crying in pain every once in a while, especially when you get close to her and start examining her. In terms of her breathing, her rate is normal. The air entry is normal. Her color is normal, and her oxygen sat is 96%. In terms of her circulation, her capillary refill is her capillary refill is flash. The AVPU score, she's not alert, right? But she is waking to verbal stimuli. So she's a V on AVPU. In terms of her color, she's a little bit pale, has the sunken eyes, but she also has like some areas of her body where she looks like bright red. She has an EKG is in the works, and I have her vitals over here on the corner for you. So this patient is slightly warm, so 38.8. Heart rate is 201, so that's really fast. She's 1 year old, by the way. She's 12 months. Her blood pressure is 65/40. Her respiratory rate is 30, which is technically in normal range. And her stat has come up to 99% actually. So for this patient, our pediatric assessment triangle is altered mental status, and her perfusion based on her heart rate, based on her blood pressure here, is also compromised, right? The flash capillary refill, the bounding pulses, the low blood pressure, especially in the setting of a high fever, makes me think septic shock. In septic shock, we start early goal-directed therapy with fluids and antibiotics. You really want to be addressing this patient's blood pressure and their heart rate within the first hour if possible. So you're going to get your whole team in the room, get 2 IVs, put the patient on some oxygen for comfort, and start IV fluids in boluses. This patient is likely in decompensated shock, right? Because the blood pressure is low and the heart rate is high. And she's actually super tachycardic. This is pretty high for a 1 year old. With fluids though, you should see an increase in the blood pressure and a decrease in the heart rate in most patients. If you get to the point where you've given up to 60 milliliters per kilo in 20 milliliter per kilo doses, and the patient is still having low blood pressure, or if the patient has any sign of fluid overload, so their liver is down, they have crackles in their lungs, then you need to start pressors or vasoactive medications. Get antibiotics in early in a patient like this, because the earlier you give the antibiotics, if it is a bacterial cause of shock, the better the patient will fare. And yeah, it is again a team effort where you have some people putting on the monitors, some people putting in the IVs, other people doing a reassessment over and over and over again. So let's move down to disability for this patient. So GCS, we said that she's kind of crying to pain. She opened her eyes a couple times to voice, and she's moving all her extremities. So her GCS is probably about about a 12, maybe an 11 for a baby. We'll discuss that in a second. Her pupils are equal round and reactive to light. And this is definitely a patient who I'm going to be getting a blood glucose on because bacterial infections can cause hypoglycemia, okay? And then skin and injury is also something to keep in mind with every patient. So quickly, just addressing AVPU. AVPU is a good tool that will help you transition from the cardiac assessment, so C to D. It ties in both. You can't have a normal mental status if you're not perfusing your brain. So if your perfusion to your brain is compromised, your AVPU will be compromised. Disability is your neurologic exam, basically. So this is a really good way to help you move from C to D. And just remember that an AVPU of a P, so the patient only responds to painful stimuli, is about a GCS of 8. So that's a patient who you really want to be intervening on immediately, who may require intubation if you don't get an improvement in their GCS. Exactly, septic shock, meningitis, those are 2 things that I was definitely thinking for this patient as well. All right, this is the pediatric GCS scale. It's a little bit different from an adult because a lot of patients that I see will have incomprehensible speech, right? That's not something that I can base a mental status assessment on. So in the child, in the verbal is really where it changes. So yeah, eyes is the same. So spontaneous eye opening, you get a 4, 3 for speech, pain only 2, and no response is a 1. The best verbal response in an older child who can speak, they're oriented and appropriate. Number 2, confused. Number 3, inappropriate words. Number 2, opposite way, 5, 4, 3, 2, incomprehensible sounds, and then 1, no response. This is the same as an adult. But for babies and infants who are still not verbal, this is where there's a lot of change. So the baby coos and babbles is normal. If the baby has an irritable cry, that's a 4. If the baby cries to pain, that's a 3. Moans in pain 2, and no response 1. And then there is just a little bit of a difference in motor as well. The older child will obey commands. The younger child will move spontaneously and purposefully. And then the other ones follow, which are about the same. Withdraws in response to pain is all the same. This is hard to do in the moment. So this is another one of those scales that we all carry around reminders of on our badge, and that it gets easier over time. So it's important to practice it, to know what you're doing, and then to help offload onto your second brain if you can. Okay, so let's revisit this patient from the very start of the presentation. This is the last patient we're going to see today. Thank God, our shift has been long and tiresome. We're all ready to go home. So pediatric assessment triangle wise, this patient looks about 2 months old, and they're totally splayed out. So already I'm thinking, okay, tone, mental status. Let's pretend this baby isn't sleeping necessarily and resting, but this baby is actually like not responding very well when you walk up to the baby and not waking up to voice. Babies this age and babies under 6 months like to be flexed. So they have flexion of their elbows, flexion of their legs. You've probably seen, if you've ever changed a baby's diaper, especially when they're in the neonatal period, everything is flexed, right? A baby who comes into your ED or your emergency department and is completely splayed out like this should make you reassess them and go see them really quickly. So this patient, you walk up to her and you get a brachial pulse. It's normal. Is there a history of trauma? Actually, you don't know, because this patient was brought in without a parent. It was brought in by somebody else, like an emergency medical provider or maybe a neighbor, and they're just kind of not responding. Airway, it's open, it's maintainable. I don't feel like we need to intubate this patient immediately. She's breathing okay. There's no sign of obstruction in the airway. You move on to circulation, and she has a capillary refill of her breath sounds, breathing. Her rate is normal. You listen, there are no adventitious breath sounds, no extra breath sounds, and her saturations are normal. Circulation, her cap refill is 2 seconds. She's not really responding to you as you're undressing the patient. So most babies at this age, as soon as you take their clothes off, which you should do for every single patient, will wake up and they'll be very bothered by the cold. This baby's not moving very much. So not until you pinch their finger does she kind of like stir. Her color is okay. Her systolic blood pressure is normal for age. So you're okay. Maybe at disability is where the money is. This is where I'm going to start focusing in on now, because everything else hasn't really led me down any particular direction. The baby's GCS, you calculate it and it's about a 10. So the baby is kind of opens her eyes to pain. She's crying to pain when you're examining her, and she's really only moving, when you're stimulating her significantly. Her pupils are equal round reactive, and you're like, all right, the first thing I'm going to do for this baby is check a random blood sugar, especially because she's here without a parent. So who knows when the last time this patient ate was. And this is where we find that this baby's blood glucose is a 45. Okay. So we're going to immediately give glucose. You can establish IV access and give D10 water boluses. I generally like to have it hypoglycemia. Exactly. Nice work. I like to use this rule where the concentration of the glucose and the volume should add up to 50. And that might be different in different practice settings, but we will do D10, 5 mLs per kilo, and then reassess. The problem is when you give a bolus of glucose, you get a spike in your blood glucose, and then your body will drop again, especially in little babies who don't have great glycogen stores. So for any baby who you're giving a bolus of dextrose or glucose to, you should be starting them on maintenance IV fluids to prevent the drop. Okay. Exactly. Rebound hypoglycemia. Exactly. So hypoglycemia is actually kind of, it's simple to find. It's where the money is. So I would get this random blood sugar on any patient who's not behaving the way that you expect them to. And I also think that it's something that a lot of times we forget because we're focused on some of the other parts of the pediatric assessment. This is a really important one. Okay. And then on exposure for this patient, you see you've totally undressed the patient. Everyone's helping you get the blood glucose addressed with D10 water boluses. And as you're undressing the patient, you notice that there are some bruises on the patient's shins. Okay. What do we think about bruises on the shins of a patient who is like around 2 months old? Normal or not normal? Yeah, bolus D10, then maintenance RL and D5. Yeah, exactly. You can do LR or NS. We would probably do half NS here for babies who are 2 months old, but LR is perfect too. And D5, you could do, we sometimes will do up to D10 for babies who are in the first 2 months of life, but D5 LR is a perfect choice as well. Distress or assault, not normal, not normal. Exactly. Abuse. Yeah. So I bring this up because as healthcare providers, when we're seeing patients, we're seeing a population that's vulnerable and at risk. Kids are not independent. They depend on adult caretakers. And if we can intervene when we see something like neglect or child abuse, which this case was meant to represent, then we can really save a life. Try to remember developmental milestones. If this baby can't really even roll over because she's 2 months old, there's no way she's going to have bruises on her shins. Okay. A toddler who's running around and super active, definitely bruises on shins is normal because they're just tripping and falling and playing. But a little 2-month-old really shouldn't have any bruising at all. The other thing is that the location of bruises really matters, and that's something we can also talk about in detail. There are people who do whole specialties in bruising and child abuse, and so that's something that we need to keep in mind. But in general, battered baby syndrome, exactly. Rule out head injury. Yeah, so this is a baby who you might be thinking about getting a CT scan in or some sort of imaging if you're at a very high resource center. To make sure that there's no head injury. And you can consider consulting somebody who has expertise in ophthalmology, who can look at the back of the eye and look for hemorrhages, which is also a sign of sort of shaken baby syndrome. Lethal diamond, hypothermia, hypocalcemia, acidosis, coagulopathy. Okay, I learned something new today too. I'm gonna go look that up after we finish our talk. Any questions so far? I feel like we've covered a lot of ground, so please let me know.
The lethal diamond is like the lethal triad essentially of trauma. The hypothermia, hypocalcemia, acidosis, and coagulopathy. I have a question though.
Yeah.
That use of peripheral pressors in kids, that's one question. Pressors in intraosseous access. What's for pediatrics, what's that like? Or is that acceptable?
Yes. So you can give pressors through an intraosseous line. That's okay. That's acceptable. Peripheral pressors, here we generally think of that being epinephrine. Not ideal, but you can do it. And especially low dose, and dopamine. In general, though, you really want to try to get that, that central line established so that you can give the appropriate pressor for your kind of shock. Here, I would say first line for most indications would be epinephrine, like low dose epinephrine, under 0.08 micrograms per kilo per hour. If you are in septic shock, then if a baby is in septic shock, then we would think of starting norepinephrine to help with vasoconstriction. But there are just so many caveats to that because it really depends on the kind of shock and what your access is. So yes, I guess like to answer your questions directly, you can give pressors through an intraosseous line. And in terms of peripheral vasopressors, we often use epinephrine through a peripheral line in our ED if we don't have any other choice, as we're starting to get, central access. Umbilical vein, umbilical lines in young babies who still have their umbilical stump. That is definitely an option. Often the umbilical stump kind of like dries out and shrivels up by the time the baby is, a few days old. So so you want to get that in early if the baby is in the NICU or the neonatal ICU, because after the first day or two, it becomes kind of difficult to get that umbilical vein line or that umbilical line. Giving D10 bolus, can we do per rectal in case we don't have an IV line? I don't know the answer to that. I've never done it per rectal. Do you know, Dr. Washira, if that's an option? Kennedy, I don't know, but that may be an option.
Probably NG tube, not rectal. You can put on an NG tube and put it down the NG tube.
Yep, that's definitely an option. And with rehydration with babies, actually, if you can rehydrate them through their gut, so if you can get an NG tube in and give them either dextrose containing solution, like something like Pedialyte is what we use here, but electrolyte like a salt and dextrose solution. That's better than giving something IV. Or if you can get the patient to stop vomiting, stop gagging, or take something by mouth themselves, then that is also preferable to an IV in a younger baby. But of course, if the patient is crashing, like the patients we've been discussing today, then you then get that IV access as soon as you can and start resuscitating the patient through the IV line. Adrenaline only you can give if baby is intubated. So sometimes you can give it if the baby is not intubated. This is a case where I would be talking to the neonatologist and making a plan with specialists here. I'm thinking mostly of kids who are in my ED who have like septic shock, for example, and still don't have a central line, but are mentating well and breathing okay. And you're really just trying to create, to improve their blood pressure so that you can perfuse the end organs better. In that case, while you're waiting to get central access, you can use peripheral vasopressors. But I would be talking to your intensive care unit colleagues if you have them available when you're starting to do that for guidance, because every case is just so different. It's a little bit difficult to generalize. Okay, so one last thing that I want to talk about, the limp baby who we just talked about in that last slide. This is an extremely wide differential, okay? It could be so many different things. And especially if the baby doesn't present with a caretaker and you don't have a history, you need to remember that this could be a lot of different things. So number one, a limp baby, prematurity causes limpness. So if the baby is premature, you don't expect them to have the same muscle tone as a baby who is the same post-gestational age because their muscles have not had as much time to develop. Hypoglycemia, which is what this last case was, always important to keep in mind. Get a random blood sugar on any patient who you're worried about. Sepsis, right? Incredibly important to keep in mind. Hyperbilirubinemia or kernicterus, malnutrition, genetic or metabolic disorders, less common, but definitely think about them, and then congestive heart failure. Sepsis is the one that I want, and like I mentioned at the very beginning of this slide, your history can help a lot. And this is one of the ones where you want to be getting that information from the caretakers to be able to adequately treat the child. Sepsis. So another topic that deserves its own presentation, but sepsis in a baby under 2 months is an emergency. A fever in a baby under 2 months is an emergency because they don't have the immune system to fight off infection. So they can get really sick really fast. There are lots of different tools and decision rules that you can use to decide how much testing to do on a baby under 2 months with a fever. And honestly, it changes from context to context how much risk you're willing to accept. So for example, the American Academy of Pediatrics just released guidelines last summer, so about a year ago, that presented new evidence to show that after 28 days of life, so for the second month, the risk of meningitis is so low in babies that we don't necessarily need to LP every single one of them if their inflammatory markers are normal. So there's a new push for a stepwise approach in babies who are over 28 days if they are well appearing. So the approach is you get what we call like an ANC, so an absolute neutrophil count, and a procalcitonin. And if neither of those are elevated, then you may be able to avoid an LP if the patient is well appearing and you're not, and otherwise okay. Under 28 days of age, the baby needs everything. The baby needs most of the time blood cultures, a complete blood cell count, urine dip, urine cultures, and most likely a lumbar puncture or an LP. There are, a lot of places where up until 2 months, there are no questions asked. You get it every single time because your turnaround from the lab is going to be too long to make a decision based off of that initial inflammatory marker result. And in that case, the risk of meningitis is still high enough where I would say you want to go ahead and get that lumbar puncture for any baby with a fever under 2 months of age, in addition to the other testing. And you start the baby on broad spectrum antibiotics while they're recovering. Or sorry, while their cultures are cooking. Okay, so the last thing I wanted to do, kind of similar to Dr. Washira, is show a well done A to B assessment of a sick child. This is our friend who is a nurse, and she will walk us through this last assessment.
Okay, this morning we're just going to go through our A to E assessment. This is Peter. He's 5 years old. He's been in your ward for the last 3 days. He's a known asthmatic and has had one previous admission with asthma. Mummy has come up to you. She's quite concerned about him. She's found him very difficult to rouse this morning. So you've been asked to come and see him. So we're just going to go through our A to E assessment and the things that we need to be looking for. Approach Peter. Peter, good morning. Can you hear me? Peter, open those eyes for me. So you want to talk to Peter. If he opens his eyes, you're happy enough that he's responding to you. I can hear that he's wheezing, but I'm happy enough that his airway at this moment in time is patent. I'm going to go on to breathing. So I'm going to check his respiratory rate, and at the minute his respiratory rate is sitting at 50. That would be higher than what we would be happy with. So his respiratory rate's 50. We also need to actually look at how hard he's working to get a breath. So you're just going to expose the chest and tummy area, and you're actually going to look at use of accessory muscles. So we can see that he's working quite hard. He's using those tummy muscles. There's intercostal recession and also some tracheal tug. So he is working quite hard. We'd have a concern about his breathing, primarily on his respiratory rate, but also on his work of breathing. So we're going to do an intervention. At this stage, we can actually check what his oxygen saturations are like. They're 90. He's on room air, and we're going to actually give him some oxygen. What we want to do is use a non-rebreather mask. We're going to attach it to the flow meter, turn it up to 15 litres. But before we apply the mask, we need to make sure that the reservoir bag is filled. So just make sure that that's filled and explain to Peter what we're doing. Peter, we're just going to pop a little bit of air just blowing around your face there, all right? Make sure that it fits nice and well. And when we've done an intervention, we want to go back and reassess to see if that intervention has been effective. So whenever I speak to him, Peter's still opening his eyes. I can still hear him quite wheezy. The oxygen's on, and our SATS monitor is on, and we can see that his oxygen saturations with the oxygen on has come up to 97, so that is effective. I'm happy enough to progress to C. When we're assessing circulation, if you start at the fingertips and work your way up the arm, you'll never forget any part of circulatory assessment. So we're going to touch Peter, we're going to feel his hands. His hands feel quite cool to touch. We're going to check capillary refill, and when we check capillary refill, we press for 5, and it's 1, 2, 3, 4, 5. Release, and we want to see return of circulation within 2. If it's delayed, then we have a concern about his circulation. Further up the hand, as far as the wrist and the low, we have a monitor on, and we can see that his heart rate is quite high at 157 there. We also want to check his pulse manually, because it will tell us whether it's weak or thready or bounding, and whether it's irregular or not. So his pulse is quite weak, it's quite thready, and it is very fast. It's certainly higher than what we would want it to be. So again, we'd have a concern with that. Going further up the arm, we can see that Peter's cannula in, but we also want to check a blood pressure, and we might think about giving fluids, but we need to speak to the doctor first of all about that. Going to check the blood pressure, so we have our Dynamap on. We'll check our blood pressure on the screen, but if we have a concern about the blood pressure or it doesn't record, we need to do a manual blood pressure as well. Further on up the arm and round to the kidneys then. So we want to be asking Mummy or Peter, have you passed urine this morning? So Peter's not really responding to me except to open his eyes to voice, so we're going to ask Mum, has Peter been to the bathroom this morning and passed urine? And that's quite important to know as well as part of your circulatory assessment. So going on to D, which is our disability, we're looking at AVPU. We speak to Peter. Peter's opening his eyes to voice, so he's responding to verbal stimuli. We'll need to record that on our PEWS chart. We also need to look at pupil reaction, so we can actually shine a light. You need to check both eyes. We also need to look at what drugs or medication Peter's been given. And from his Cardex, we can see that he's on regular nebulizers and paracetamol as he requires it for temperature. We also need to consider blood glucose at this stage as well. So we're going to do a BM. Just check a blood glucose, and his blood sugar is 3.8, which again is slightly lower than what we would expect. So we'll need to record that and escalate it to the doctor. Happy enough with my assessment of disability, we're going to go on to exposure. So for exposure, there are 4 things that we're particularly looking for. We need to look both at the front and at the back. So we're looking for rashes, bleeding, bruising, and any swelling. And again, if we notice any of those, we need to record it. Once I've checked all Peter's vital signs, I'm going to record them. I'll calculate his PEWS score, and I will escalate that to the doctor, voicing my concerns. And that will be done through SBAR handover.
Hello, this is the doctor. Hi, this is Jill, one of the staff.
Okay, SBAR handover is a separate topic. So sorry about that. I tried to press on the chat during the video and it stalled a couple times. Any questions, Dr. Washira, that you think I should address? I know we're kind of at the end of the hour here, or the hour and a half.
Yeah, there was something about caffeine citrate. I have no idea what that is.
Yeah, so caffeine citrate we use a lot in babies in the NICU, so in the neonatal ICU if there's apnea, especially apnea of prematurity. It's really helpful in that context. I haven't used it in others, but you can use IV caffeine for babies who have apnea of prematurity.
All right, final question. Is there a role for aminophylline in kids? I know in adults we don't do that. We don't use that anymore. I don't know, but is there a role for aminophylline in anything in pediatrics?
Yeah, so that's a great question. The only time that I've used aminophylline has been in children who are in status asthmaticus, who are not responding to continuous albuterol who have gotten steroids, who have gotten IV magnesium and a bolus, and are still in, significant distress. I have seen our pediatric ICU put kids on aminophylline infusions. There is a little bit of debate between aminophylline versus theophylline. And there's actually, our emergency department prefers theophylline and the ICU prefers aminophylline. So I personally haven't done the literature review to figure out what the difference between those two is and why we use one versus the other. They're both safe medications, but it's just a matter of preference, I think, based on some of the outcomes in studies that have been done comparing them. But the only indication I've ever seen it used for in children has been persistent status asthmaticus.
Hi, thank you, Alexa. Bernard, I'm not sure about in AKI, but yeah, I'm seeing the same in respiratory distress in MBU. I think we'd have to look at the studies that support some of this.
I just wanted to say the last slide of my presentation has a lot of useful resources if you're interested in learning more, and this has sparked, a passion in pediatric emergency medicine in you. These are really wonderful places to explore more. There are links in the presentation, but you could also just Google these: Open Pediatrics, Learn PICU, Rebel EM Pediatrics Archives, and then PEM Cincinnati, the podcast, and Pediatric Emergency Medicine Playbook. If you have Spotify or if you listen to Apple Podcasts, you can download them on both and get little bite-sized audio teachings on pediatric emergency medicine. And if you have any questions, I'm happy to answer any you have via email as well.